Hi, my name is Megan Maddox, and today I'm going to tell you about the critical incident that occurred during my practicum hours. On the seventh day of my practicum, I experienced an incident that challenged my knowledge and skill level, as I was caring for a postpartum mother and her 16-hour-old newborn weighing 5 pounds 5 ounces. During my morning assessment, I noticed that his respirations were 65, a sign of tachypnea in a newborn. I immediately notified my preceptor of my assessment finding, and she agreed with my respiration count. She said that we will compare our finding to the respiration count of the previous nurse, and we found that the newborn had consistently had high respiration counts of 57 to 62. A message was sent to the pediatrician notifying him of our finding, and the response was to monitor the condition of the infant and look for other signs of respiratory distress. Our first intervention included placing the infant skin to skin with his mother, which led to a decrease in respirations of 55 to about 60. After an hour, we reassessed the infant and found that his respirations were 56, within the normal range but on the high end. The newborn was due to eat, so we began assisting the mother with breastfeeding, as his chart indicated that he had minimal intake during the previous shift, when we were hoping to improve his intake and ensure his blood sugar would not begin to drop. We were able to assist the mother to feed her infant with a syringe at the breast, and the newborn was able to take in 5 mLs over 25 minutes. However, his respirations began to increase, this time up to 65. We made the decision to hold off on feeding and to resume skin to skin and to continue to assess, allowing for his respirations to drop back into the normal range. Around noon, the mother requested that we bathe her infant, and after much contemplation, my preceptor decided to do a very quick and minimal bath and to prevent unnecessary stress on the infant. However, after the bath, the respirations began to rise, this time to an abnormal value of over 70. However, he had an oxygen saturation of 98%. We messaged the pediatrician once again, this time requesting that he comes to assess the infant. During his assessment, he decided that an x-ray should be ordered and that a blood draw should be performed in order to rule out the beginning stages of septic shock, as the newborn had a relatively traumatic birth experience. His mother had AROM for 24 hours before he was delivered, during which it is believed that she had a partial placental abruption that resulted in hemorrhage. The newborn had to be deep sectioned, and this brought forth about 50 mLs of blood from his airway. The pediatrician also decided to withhold feedings until the return of the x-ray. Within an hour, the scan had been read, and it was determined that he had a moderate-sized pneumothorax in his right lung, a finding that directly accounts for the findings in the infant. Due to his decreased lung capacity, he was working much harder than he should have to been able to breathe, and he was choosing to breathe over eat, which is why he had such minimal intake, and the lengths of his feeds were extremely long for the amount of milk consumed. After explaining the situation to his mother, she was distraught and emotionally overwhelmed with the situation. So my preceptor and I stayed with her and comforted her while the pediatrician contacted the NICU at Rainbows for guidance regarding the next steps. This all occurred while her husband was at home showering and getting them food. It was determined that at that time the newborn was borderline on if he should be transported or continue to be monitored at Geauga Medical Center for the time being. The plan was to continue to have frequent assessments, assessing Q2 vital signs, oxygen saturation, and if the respirations became 70 or higher, he would be transported. On day 4, my patient was transported to Rainbow's NICU due to non-significant signs of improvement with breathing efforts, lack of significant improvement with his feeds, his weight loss percentage, and repeat x-rays that did not show significant signs of improvement. This situation was concerning to me because it was new and like no other situation I had been in before. I have only had experience with pneumothoraxes after they have already been discovered and measures have already been taken. This was new to me because I was there for the discovery of the problems and the discovery of the pneumothorax. I was also unsure of how to really comfort or reassure the mother, because this was the first time I have cared for a newborn that was not thriving as they should. I had also never experienced being a part of catching the problem and was a little concerned to keep reporting tachypnea, as I was scared that my own assessment was incorrect and I was causing alarm when there shouldn't be any. but it was reassuring to hear that my preceptor continuously got the same assessment data as myself, helping to boost my confidence with my assessment abilities. When looking at the ethical implications of the situation, all of the ethical principles, autonomy, non-maleficence, beneficence, and justice, were used. I will talk about each one in particular. Diving right in with autonomy, the ethical implication with autonomy began with the fact that the patient in distress was a newborn who was under the decision-making responsibility of his parents. His parents were first-time parents and have never had to make a decision for a child before. However, at less than 1 day of life, they were forced to make important decisions for him, something that was very scary for them, as I'm sure it would have been for any first-time parent. They kept saying that they just wanted to do what was best for him and to do all that we could to keep him safe. If the patient was not a child, he would be making his own decisions, but in this situation, the choices fell to his parents. Non-maleficence is to do no harm, and I felt that this was violated by the 5 blood draw attempts that occurred when trying to draw the requested lab. While myself and the other staff did all that we could to keep him comforted, I'm sure he was still experiencing pain that he had never felt before, time and time again. I feel that there is a point that must be considered when more harm is being done than good. Additionally, I felt that this was violated by the decision to do the bath, no matter how quickly it could be performed. If there was a chance of making the situation worse, I feel that the mother should have been told to wait until the newborn stabilizes further to avoid the risk that we would be taking. As for beneficence, to do good, I feel that this was violated by the choice to continue to keep the newborn at Geauga Medical Center for treatment instead of sending him to the NICU. I feel that this was denying the newborn of even better care that could be provided at Rainbows due to the lack of specialized NICU knowledge and resources at Geauga. And finally, also similar to beneficence is justice, or to be fair and equal, which I feel could have been violated through the choice to keep him at Geauga instead of transferring him to the NICU. By keeping him at Geauga, he would have been the sickest patient on the mother-infant unit, but if he were to be sent to the NICU, he could possibly be the healthiest infant and could be keeping a bed from a more critical patient. It is hard to be fair or equal at all times, and I feel that this decision may have violated the principle or implication of justice and potentially non-maleficence, as it could have caused more harm the longer he stayed at Geauga and was not receiving NICU-level care. I will continue to talk about the actions taken regarding the implications on the next slide or two. When looking at actions taken for the situation I have described, many actions occurred during my practicum shift, many of which I was able to perform myself or assist to perform. Starting at the beginning, I was doing my head-to-toe assessment on the newborn when I discovered the tachypnea he was experiencing, as well as the finding of the retractions he demonstrated after trying to nurse. After much assessment, following actions included feeding assistance through a syringe at the breast to allow the newborn to not have to work so hard while trying to nurse, hoping to keep his respirations below a concerning level. While I did not perform the x-ray, I was there to assist the technicians in positioning the newborn and help to ensure that he remained still and comforted during the prep and after the scan was complete. I was also able to witness the pediatrician examine the image before it was sent to the radiologist to be formally read. I performed Q2 vitals after the persistent tachypnea and reported each of my findings to my preceptor, who relayed our information and findings to the pediatrician. I was also able to perform the pulse oximetry reading on the newborn, as we wanted to make sure that his oxygen saturation remained within the normal limits, as if it were to fall, he would be transported to the NICU. I was also able to assist during the numerous blood draw attempts. However, the actual attempt was performed by 2 nurses on the floor as well as a pediatrician. I was able to assist by staying up by the newborn's head and by comforting him through the use of my voice, my finger, and sweetums, as well as all of us trying our hardest to keep him from crying, as we did not want to increase his stress levels and increase his respirations further. Unfortunately, all of the blood draw attempts were unsuccessful, and the NICU did not think that it was critical to obtain a level at this moment. However, if he were to deteriorate further, the lab draw would be helpful and necessary. And while this next action did not occur during my shift, it did occur after, so I thought I would include it. The newborn had high bilirubin levels and was eventually placed under Billy Lights to combat this before heading to the NICU. constant assessment by us and the parents was necessary to ensure that the newborn did not take a turn for the worse and to ensure that if he did, it was caught immediately. And while it does not pertain to her newborn, I took actions to comfort, educate, and reassure his mother, as she was unsure of what everything meant and was genuinely scared for his condition and even his life. Being her first child, she was new to being a parent, and having a sick newborn while experiencing postpartum emotions and hormones was very overwhelming for her, so I made sure to take the time to sit with her and reassure her the best I could, given the circumstance and the so many unknowns, and to just be an ear to listen while her husband was not in the room. Now, looking at the ethical principles and how they were corrected or what was lost. These were previously discussed, and I will discuss the actions taken to correct them, as several things were taken and corrected during the remaining hours of the shift and through the admission of the newborn, or through the discharge of the newborn. My preceptor continued to care for the infant while he was sent to the NICU, so I was able to reconvene with her and discuss the outcomes at our next shift together. First, autonomy. I felt that this may have been violated when the provider decided to transport to the new I felt that this may have been violated when the provider finally decided to transport the newborn to Rainbows, as this was his decision to do so and not the parents, although they were willing to take any means to help their child, as expressed earlier. The parents were told every aspect of the situation, including the findings, the risks, the benefits, and the potential outcomes, allowing them to make the best informed decision regarding their care and treatment choices for their child. But once again, they were the ones making the decision for the child, as he clearly was not old enough to make the decision for himself. The parents were encouraged to use the principle of autonomy and were able to do so with the majority of the decisions made regarding the care of their child. With non-maleficence and beneficence, sometimes it comes down to weighing the risk versus the benefit for the patient. I had discussed how I felt this was violated with giving the bath that led to tachypnea once again, and the numerous unsuccessful blood draw attempts. This was corrected when a night shift nurse was successfully able to obtain the sample that indicated that the newborn was not heading towards septic shock as potentially thought. This could also be seen as corrected when the newborn was finally transferred to the NICU to receive additional care measures in a more intensive setting before heading home. I felt that this should have been done earlier than day 4, however, I was not there in the additional days of care at Geauga, so I am unable to shed light or reflect upon how his condition changed or progressed during that time. And as for justice, I feel that justice was corrected or served by the transferring of the newborn to the NICU to continue to receive additional monitoring or care. I believe that this allowed for him to receive the best care possible in the proper setting and would allow for the nurses at Geauga to be more present in the care of the other patients on the unit once again, as they would not have to keep their constant eyes on the newborn to watch for signs of progression or degression. I feel that if the NICU felt that he was not in need of their critical care, the pediatrician would have been advised to keep him at Geauga. Because of this means that they had room and the ability to allocate their resources for my patient. I feel that all of the ethical implications were eventually resolved for this newborn. However, I still believe, as well as my preceptor, that the transfer should have happened sooner, which would have allowed for quicker action and treatments if they were necessary to give this newborn the best chance at being as healthy as possible. Looking at the outcomes of the situation, it is what I had predicted would happen. However, it happened much later than I thought. I was able to talk about the outcomes with my preceptor to gain insight on the outcomes of the situation. The patient continued to receive care by the nurses at Geauga until day 4 of life, when he was finally transferred to the NICU at Rainbows. His mother herself was discharged, so she was able to go with him when he was transferred. He continued to receive Q2 vitals, feeding assistance, and lots of time doing skin to skin. His weight was also closely monitored to ensure that he did not have critical weight loss. He also had daily or twice daily x-rays to monitor for pneumothorax progression or resolution. The pediatrician predicted that he would not have to spend a significant amount of time in the NICU but he wanted him to be transferred to have a closer examination from the NICU specialist and to receive any additional interventions that they could implement to give the newborn the best outcome possible. This situation was one that I had not encountered before, as I am usually working with patients that have already been diagnosed with the condition. However, this time I was part of the diagnosis. Truthfully, I was doubting my assessment abilities when I kept reporting that the newborn was having tachypnea. I was nervous that I was starting to cause alarm when there shouldn't be any. However, my findings were correct and I was part of the diagnosis. The situation did have many moments that challenged the ethical principles. However, throughout the rest of the shift in the newborn stay at Geauga, I feel that most of the principles that were challenged or violated were resolved. This case allowed for me to really be present and to see the importance of communication amongst the healthcare team and the importance of collaboration amongst specialties. Honestly, I had no idea how a pneumothorax could arise in a newborn, so I did some research during the clinical day after the finding and discovered that the article titled Pneumothorax Prevalence and Mortality per Gestational Age in Newborn was a great help in giving me a quick overview of pneumothoraxes in newborns and helped me to realize how my newborn I was caring for fit into the category of patients at risk. The article stated that pneumothorax in newborns is a life-threatening condition associated with high morbidity and mortality, especially in premature infants. I quickly thought back to the information I already knew or witnessed while the newborn was born at 38 weeks, the baby was extremely small and scrawny looking, and the creases on the feet did not look like the feet of a full-term newborn, a finding that both myself and my preceptor discussed. It almost seemed as if the newborn was not gestationally as old as predicted, and that there could have been an error or discrepancy in calculating the date of conception. The article also stated that in all live births, the incidence of spontaneous symptomatic pneumothorax was reported to between 0.05% to 1%. However, in infants admitted to the neonatal intensive care unit, reported pneumothorax rates were 2.8% to 9%. The incidence of pneumothorax varied widely depending on the underlying lung condition, birth weight, resuscitation techniques, and method of administering assisted ventilation. The newborn I was caring for had both a low birth weight of 5 pounds 5 ounces, and while he did not have to have true persistent resuscitation techniques, he did have to be deep suction that produced 50 mL of blood due to his mother's partial placental abruption and resulted in low APGAR scores initially. The article also stated that in infants diagnosed with pneumothorax, the overall mortality rate was 8.8%, another statistic regarding pneumothorax that I did not know. While the statistic is under 10%, I was surprised that it is still as high as it is, and I found it to be pretty alarming. After learning of the 8.8% mortality rate, I was even more in agreement with the consideration of transferring him to the NICU so he could have the best chance and outcomes possible. Heading to the NICU myself after graduation, I am sure that I will see many infants with lung abnormalities such as pneumothorax. After having cared for this newborn, I have continued to do some of my own research and have an interest in learning so I can have a better understanding of the condition, treatments, and outcomes before heading to the NICU. I know that I will have many cases in the future where the ethical principles will be challenged or violated, and I will work my hardest to make sure that any violations of these principles will be corrected and upheld. I understand the importance of these principles and just how easily they can be violated, and I have been and will continue to ensure that the wishes of the patients or their guardians are heard, shared, and protected. This is the source that was used in my presentation. Thank you so much for listening about my critical incident, and I hope that you have learned additional information regarding spontaneous pneumothorax in a newborn. I am thankful for all of my experiences I have encountered during my practicum at Geauga Medical Center on the mother-infant unit. However, this incident in particular challenged my skills and knowledge and helped to push me to continue to further my education always. I know that I will always come across challenges throughout my career, but I want to ensure that I am able to work through any challenge while respecting and upholding all of the ethical principles, helping to provide the best care possible to each and every one of my patients. Thank you.